Lane, do you want to? There we go. We're recording.
All right.
You want to do the roll call and everything?
Yes, so we'll do, first off, I just want to say, I hope everybody had a wonderful, lovely holiday weekend. And it's good to see everyone. So for roll call, just call your name. And if you are here, just say present or here, or raise your hand, or however you want to let me know that you're here. Robert Bennett, see you. So you're good. I can unmute. There we go. Samantha Davis.
Present.
Emily Gunston.
Present.
Ronald Hampton.
Here.
Lashunda Hill. I believe she said she's having issues with Zoom today. Corwin Knight. Who I see.
Here, I'm here.
All right. And then Sultan.
I am here.
All right. I'll turn it back over to you, Sultan.
Sounds good. Well, first, I just want to thank Jennifer, Bethany, Catherine, and the team for working with Lashunda and I on pulling together this meeting and this agenda. They've been incredibly helpful with helping us staff this committee. So I just wanted to say that thanks at the top for all of your work. And with that, I would like to introduce our guests for this evening. We are joined by University of Maryland professor Dr. Joseph Richardson. He holds a joint appointment in the Department of Anthropology and the Department of Epidemiology and Public Health at the University of Maryland School of Medicine, and his research focuses on gun violence and trauma among Black boys and young Black men. So we've invited him to speak about his work and his knowledge on the subject that we are here as a commission and particularly as a committee to study and come up with recommendations for the mayor and the council early next year. And so with that, I just want to thank Dr. Richardson for joining and turn it over to him.
Thank you, and good evening, everyone. Thank you for inviting me to speak tonight. I have a very interesting presentation to make. I am the producer of a digital storytelling series called Life After the Gunshot, and I have some clips on trauma that from interviews with young men who are survivors of firearm injury, who are also involved in the criminal justice system as well. And if I get through all of the slides, I'll go back and play some of those clips if I'm able to. So I just want to give everyone a heads up for that. So I will start my presentation. So you all know who I am, so no needs to go through that. But I also want to make this as interactive as possible. So I thought that this would be a great way to start because we have not thus far over decades treated gun violence as a public health issue or crisis in our country. And I'll get back to the 1996 bill, the Dickey Amendment, which had an effect on what we know about gun violence in our country because it prohibited the federal government from funding the CDC and the NIH to engage in gun violence research. So I will get back to that, but I just want to make sure that we all are on board in terms of that gun violence should be treated as a public health disease. So I have a few images here, and I just want to get an idea from all of you. When you see these images, what comes to mind collectively of the 6 images that you're seeing? And feel free to chime in.
Slavery.
Okay.
I put in the chat state sanctioned violence.
Okay. Great answer.
I would say the destruction of Black people.
Okay. Great answer. What they all have in common, and those were all really good answers, is the tie is structural violence. And so what I want to do from the outset of this conversation is frame violence not only as fist, stick, knife, and gun in the ways that we typically understand violence, but also to frame violence in ways where violence could be seen as perpetrated by social institutions, harming and preventing people from meeting their basic needs. And so we think about in terms of the COVID crisis, and at any point, hopefully within the next year, we'll have a vaccine for COVID. If 5 years from now, if there's COVID is still existing and still thriving in the world, if there are a population of people knowing that we have a vaccination that have not received it and are affected by COVID and die, would we consider that to be a form of murder or harm? Brian,
We
I
should.
see we should, correct?
Yeah, yeah.
Exactly. So racism should also be seen as a form of structural violence, and we should bring more attention to structural violence as a way of framing violence, not just as interpersonal violence, but also violence that could be perpetrated by social institutions and particularly by governmental institutions. So again, we have a narrow conception of violence. We typically think of violence in terms of violence as guns, knives, batons, and fists, but we can also think about violence in terms of direct violence is usually measured in the number of deaths, right? If someone is murdered in DC, we can measure that. But we could also approach it in terms of structural violence, looking at the number of deaths that could have been avoided or prevented if we concentrated the same level of resources that we use for the upper middle classes into the lower classes. We could prevent tons of deaths. And so just in terms of thinking about COVID again, how many deaths could we have prevented in the COVID crisis had we addressed the pre-existing conditions that many low-income African Americans, and I would even go beyond just low income, but generally across the board, that African Americans face in terms of access to quality healthcare. And so these are what we call the social determinants of health. And these are all the factors that can determine one's health and the quality of life and your life expectancy. So in terms of education, we know the more education that people get, the more likely they are to increase their income and wealth, and that are more likely to be employed, more likely to have higher incomes, to live in better quality of housing, to have better access to transportation, to live in neighborhoods where they have access to quality food and don't live in food deserts, medical care. And if we think about wards 7 and 8, we know that in Ward 7 and 8, they've been classified as trauma deserts. And DC Council recently funded the bill to build a level 1 trauma unit on that side of the city. But I think one of the reasons why I'm here today is because Prince George's Hospital, which sits on the border of the District of Columbia, serves primarily 30% of all people who are violently injured in the district are brought to Prince George's Hospital because there is no level 1 trauma center in Ward 7 and 8. So what you're finding is the state of Maryland is often taking care of the District of Columbia residents because of the trauma deserts that exist in that section of the city. And so in terms of how structural violence plays out in our lives, you can see that here in Woodley Park, the average life expectancy is 89.4 years of age. But if you get in your car and you travel maybe 15 to 20 minutes to St. Elizabeth's, which is east of the river, the life expectancy there is 68.4 years. So in a matter of a 15 to 20 minute drive, you lose 21 years of your life expectancy based on those social determinants of health. And that's happening in the nation's capital. This also reflects, the larger dots reflect not only significantly more higher household earnings, but also life expectancy. So as these circles are getting larger, and if you look down into the left corner, you can also see that the life expectancy is increasing. And so there is a linear correlation between income and households that earn income or less than $15,000 and life expectancy. And as you can see, as the dots get smaller, the life expectancy gets lower. In terms of concentrated poverty, This is a graph reflecting concentrated poverty in the district over the past 45 years. And you can see in every single time period that's marked that Black poverty has increased, as well as the high Black poverty has increased in each of these decades. In terms of household wealth, which I found to be probably one of the most egregious statistics in terms of net wealth in the district, is that white households have 81 times the net wealth than Black households in the district, $284,000 to $3,500. This is often reflected in who owns their homes and where those homes are situated. And so this map provides an illustration of single family homes compared to the concentration of public housing and apartment buildings. And we can see by the purple where the concentration of most single family homes are, and then the concentration of public housing and apartment buildings that are in predominantly poor Black neighborhoods, which are east of the river, which also is correlated to the last slide with net wealth. So in terms of COVID, what we see is that DC among Blacks has 6 times higher COVID fatality rate, which is also correlated to the social determinants of health. And in terms of food deserts, what you also see is not only do we have trauma deserts that are east of the river, but we also have a high concentration of food deserts indicated by the red or maroon, as you see here, and a larger number as you move further into the center of the city. And as you move into the more northwest section of the city, you often find higher numbers of walk sheds where people are able to walk to transportation and to accessible food resources. In terms of the racial gap with the school to prison pipeline, and this is the comparison of the District of Columbia for Black students that are in counties and jurisdictions in the DC metropolitan area. And what you'll see at the top graph is that Black students are 15.2 times more likely to be suspended from school than white, or expelled from school than white students. And then in the orange graph below, you'll see that Black students on average are 5 grades behind their white peers in comparison to other jurisdictions in the DMV. Again, this kind of reiterates the last slide, that students in DC are 15 times more likely to be suspended from school. And why that is so important is because school suspension rates are often indicative of high school completion rates. And we know that those who are less likely to complete high school are also more likely to end up in the criminal justice system. And so I often hear this narrative that compares 3rd or 4th grade reading averages to prison beds, but I think that narrative is missing one piece. If your 3rd or 4th grade reading averages are below the national standards, more than likely that you'll drop out of school, and school dropout leads to a significant number of people being incarcerated. And so in terms of social mobility, when you compare Black boys to white boys who grow up rich, more than likely white boys who are growing up rich manage to stay rich as they move into adulthood, while Black boys who grow up rich are more likely over the course of their lifetime to end up poor as adults. Fascinating graph. In terms of stop and frisk and what that means, on average, we find that 45 Black people are searched and frisked every day here in the nation's capital, compared to just 2 white people. But when studies have been done in terms of stop and frisk, what they found is that although whites are stopped far fewer than Blacks, they often produce more contraband in terms of drugs and guns, but are less likely, Blacks are less likely when stopped to receive a citation. And in the District of Columbia, where there are almost 30 plus law enforcement agencies in the district, many Black communities suffer from being hyper and over policed. Also, the district has one of the highest incarceration rates in the nation. And you can see here by this chart, it's almost double. And what we found in our studies in terms of repeat violent injury is that the most significant risk factor for bringing a young Black man back to the hospital is a previous history of incarceration. Now I would ask the committee, why do you think that is the most significant risk factor for repeat violent injury among this population? There's no right or wrong answer. You can feel free to chime in. So let me answer it for you. The collateral consequences that lead to felony disenfranchisement, which prevent someone who has a felony from either getting employment, living, having access to a Pell Grant or student loan, living in public housing, the inability to get certain licenses within states, all lead to the inability to be a free citizen and to be socially mobile. And so what we found is that the intersection of the healthcare and criminal justice system among young Black men, and what we found at least at Prince George's Hospital, is that 70% of our violently injured population had a history of criminal justice involvement and were currently under some form of community supervision, either probation or parole. So when you see that, that means that this is a clip. I could show it. Would you guys mind seeing this clip? It's on the intersection of the criminal justice system and violent injury among our population, or I'll wait and I'll just go back to it when we're done. So these are the number of homicides, at least in July in DC. And then on the right, what's indicated are the concentration of gunshots that were detected by ShotSpotter, which is a technology that the DC MPD used to detect the concentration of where gunshots are fired. And this is a better indication of what violence is playing out in the streets of DC, because we know that violence is often underreported. People don't typically call 911 to report gunshots, but the ShotSpotters do a great job of indicating where the concentration of gunfire is occurring. And as you can see, again, this is happening east of the river in the district. This is also a heat map, which indicates where the shot spots are occurring. And so if you think about in terms of what this all means regarding the economics of DC, you can see an inverse relationship in terms of employment growth and the gun homicide rate. And this study was conducted by the Urban Institute. So what you'll see on the right is in 2010, when there was a high rate gun homicide rate per 100,000 people, if you look to the left, you can see that the employment growth rate was low. And as the gun homicide rate decreased, the employment rate actually increased. Why? Because in Washington, D.C., every 10 fewer incidents of gunfire in the census tract are significantly related to one new business opening, the creation of 20 or more jobs in the new businesses, 1.3 million more in sales at new businesses, and one less business closure. So you can also see that there's an economic incentive and component to the reduction in gun violence. And what I would add in terms of that, recently there was I believe there was Black Restaurant Week, maybe 2 or 3 weeks ago in the district. And there were not one restaurant was named in Black Restaurant Week that was east of the river, with the exception of Busboys and Poets. So when you think about the economic impact of gun violence, you think about this chart or this data. So as of yesterday, I believe that there are now 181 homicides in the district. And last year at the same time, there were 159. And so we've seen a significant spike in gun violence in the district. And these are some of the challenges that we face when we're working with young men who are the victims of offenders of gun violence. We have to deal with environmental health hazards, lack of education, food deserts, unemployment, poor housing, and the concentration of poverty, all forms of structural violence. And so I recently published a chapter in a book that will be coming out pretty soon, titled "Why Are We Losing the War on Gun Violence in the United States?" And one of the reasons why I think that is so important relates to a report that I recently published with my colleagues that out of the John Jay College of Research Advisory Group on Preventing and Reducing Community Violence, where we looked at ways that we can reduce violence without relying on the police. And many of the ways that we've relied on the reduction of gun violence thus far has been putting more money into policing, when we know that that process is ineffective and actually does more harm to the community, creates more distrust, and also brings more people into the criminal justice system. And so, as I'm sure you all are aware, one of the NEAR Act, Neighborhoods Engagement Achieves Results, has been one of the public health approaches to reducing gun violence in the district. And out of the NEAR Act became the ONES office, which I'm sure you all are aware of. But one of the things that I want to highlight that's part of the ONES office in the top left corner is the Pathways program, which identifies individuals who are at the highest of the highest risk for being engaged in gun violence as victims, as offenders. And this program provides wraparound services in terms of substance abuse counseling, mental health counseling, and then provides subsidized employment for 6 months after 3 months of participants being drug-free. And then after that 6 months of subsidized employment, moves that population into permanent jobs. And so that model was based on the Advanced Peace Model in Richmond, California. And this is the impact that model had. And hopefully when we finally get around to conducting an evaluation impact on the Pathways program in DC, we may find numbers that are similar to these numbers. So you can see this is for 6 cohorts who have been involved in that program in Richmond, California. And this model was again borrowed in DC from the Advanced Peace Model there. And you could see that in the 37 fellows in the 6 cohort that 100% are alive, 95% have not been injured by firearm, and 76% not suspected in a firearm related crime. And then you can see for all 6 fellowship cohorts, the numbers are similar, right? So, and this is for a 9-year period. So clearly the program has been effective. This also shows the reductions in shootings in Richmond, California, which was once known as having one of the highest homicide rates in the country. And you can see there's a 28% decrease in shootings with injuries. There was a 7% increase in total homicides between 2018 and 2019. But if you do the comparison, between 2018 and 2019, there was a 33% decrease in homicides among young adults. And then in 2018 and 2019, a 36% decrease in the total shootings involving injury or death. DC also has now the Cure Violence model, which operates in targeted neighborhoods in Ward 5 and Ward 8. And the Cure Violence model has seen up to 60% reductions in shootings and killings in more than 100 cities. And they use a public health model, which is based on treating violence as a disease and using violence interrupters to interrupt the spread or contagion of gun violence. And so they interrupt before conflict results. They also treat and identify the individuals by referring them to mental health and psychosocial service support. But one of the things I would say is challenging in terms of recommendations that I would make to this committee is that these programs are often situated in one neighborhood when they should be mobile. That and the cure violence model tends to have a one size fits all approach where every city is different. So DC has a different culture of violence than Baltimore. Baltimore has a different culture of violence than Chicago because there are gangs in Chicago, or in Los Angeles, which has a history of gangs. And so the violence interruption model has to be tailored to the cities where they're situated. But I also believe that the models need to be mobile, and we need to be able to move from one neighborhood to another to respond to violence instead of being situated and locked into one neighborhood. And so this article was published on my hospital violence intervention program. This was in the Huffington Post, and it's titled "Hospitals Are Trying to Do What Politicians Haven't, Stop Gun Violence." And so this, I recently published an article on my experiences as the co-founder and founding director of the Capital Region Violence Intervention Program at Prince George's Hospital, and some of my experiences with developing and implementing that program over a 2-year period. And what we do know about hospital violence intervention programs, and I would like to say there are 4 in the District of Columbia, and actually DC, I believe, is tied with Philadelphia for the highest number of hospital violence intervention programs that are in one city. DC has 4. Prince George, which I would include as part of the DC Metro, which is at Prince George's Hospital Center, Howard University, Washington MedStar, and GW. And so what the programs have been able to do is reduce the rate of trauma recidivism by providing psychosocial services in the form of cognitive behavioral therapy, employment and educational assistance, legal assistance, and housing assistance, which is kind of challenging in the district because of the rapid growth of gentrification and lack of affordable housing. But you can see in the results when you compare here for 466 clients in a study that was done on the effectiveness of these programs, the violent re-injury rate was half compared to the control group. And so these are the numbers of injuries that come into Prince George's Hospital Trauma Center over the course of a 5-year period. And I just want you to take note that they're pretty even across the board in terms of gunshot wounds, stab, and blunt assault. But the 5-year average is 746 people per year, which is 2 people per day coming into the trauma unit. 40% of all gunshot wounds that come into Prince George's Trauma Center are from the District of Columbia, 40%. And that's the result of the lack of trauma centers in Ward 7 and 8. And why that is so important is because there is a correlation. There have articles been written on murder in medicine, which have proven that the closer you are to a trauma center, the likely you are to survive. So the further you are, the less likely you are to survive. So when you have a trauma center that's situated in neighborhoods that are experiencing high rates of violent injury, it's almost a form of structural violence when the city does not build a level 1 trauma center to respond to those forms of violence. So again, the cities, when I mention that city governments can be complicit in structural violence, these are the ways that they can engage in that form of harm. And so at my former program, we started in 2017. We had 116 participants. When we began, our trauma recidivism rate was 32%. That means 1 out of every 3 people that came into that hospital between that time had been injured 2 or more times. Sometimes we had young people who had been shot every single year. I can recall a young man who was shot when he was 17, 18, and 19 years old. That was not abnormal for us to have people who were constantly coming back to the hospital. So our primary goal as a hospital violence intervention program is to reduce the rate of trauma recidivism. If we can prevent people from coming back to the hospital, then more than likely we can save their lives and also reduce the cost on the healthcare system for every injury. And so as you can see, when we started, it was 32%. By 2019, 2 years later, our trauma recidivism rate was less than 1%. Only 1 person out of the 116 people that were in our program returned for a violent injury. Outstanding numbers. And in fact, we did such a great job that the National Network of Hospital Violence Intervention Programs, which is a consortium of 40 hospital violence intervention programs across the world, awarded us membership into their program in our first year because we were doing such an incredible job with reducing trauma recidivism. We also, 70% of our patient population were involved in the criminal justice system, but during that time, out of the 116 patients that we had, we only had one person return to be rearrested for a new offense. And so the criminal recidivism rate is up to 77%, and the trauma recidivism rate in this country is up to 65%, and 20% of that population will die within 5 years. So up to 65% nationally, right? Up to 65% of all the people who come into the hospital for a gunshot wound or stab have been there 2 or more times, and 20% of that population will die within 20 years. So I think that we were doing a fairly good job by reducing the trauma recidivism rate to less than 1%. One of the ways that we do that is we use a credible messenger who is someone that has the shared lived experiences of the young men that we work with. And that person is trained in cognitive behavioral therapy. They're also trained in conflict resolution, motivational interviewing, and meet the young men where they are. And they start that process at bedside. And so we have, we use our violence intervention specialists in ways which he's credible, but also culturally competent and understands the patient population that we work with because he's been there before as well. And so this is Che Bullock, our violence intervention specialist, who is actually, this is a shot of him meeting with a 16-year-old kid who was the victim of a gunshot wound. And this is where the process starts at bedside. This is TJ King, who was also shot multiple times, DC resident from Southeast DC. And as you can see on his tag, he has patient transporter, and we were able to get TJ permanent employment at our hospital. He had been, when he arrived at our hospital, it was his second time being shot. And I'm glad to say that since he's been employed at the hospital in our program, he now has his own apartment. He's a full-time worker and has not been injured and has not been rearrested. This is Christopher Edge. This kid was shot twice on 2 different occasions and stabbed once. But what I want to emphasize here is that this is Chris actually teaching my class as a TA. And so I use a more hospital-linked approach because what I found in my interviews and focus groups with young men is that they prefer to come up to my campus because it provided a means of exposure to a campus environment. And even though they may live 15 minutes away, they emphasize that they wanted to come to my school. And I have to say this, at every single time that they're at my school, they always ask me, Doc, how can I get into college? And so this was a way of providing them with a safe haven for them to be exposed to an academic environment. And as you can see, he looks pretty comfortable guest lecturing in my class, right? This is really important because on the left is our psychotherapist, Edward McCurdy, who actually worked with Chris providing therapy. And so when Edward left our program, they continued their relationship. And I just wanted to show this because Chris actually posted him having a therapy session with Edward on Instagram Live. This is the impact that you can have on young Black men in terms of getting them to accept mental health therapy. And I want to just read what he wrote as he was posting this therapy session, which he didn't provide sound to, but he wanted to show his peers, as well as everybody who follows him on Instagram, that it's okay to engage in mental health therapy. And so he says, I truly believe in mental health therapy and I appreciate at Soul Query, and that's Edward. 2 years of knowing this man, and I need my people to know talking to someone is a great way to deal and unknowingly heal from unseeable scars. For all my soldiers, it's a big step to take your life forward in the right direction as far as your soul. a positive energy, what your body feels after letting a few demons or all your demons off your shoulders. And this is for all ages, not just adults. I got nieces and nephews, little brothers and sisters who've been going through things no youngin' should experience or have to see or go through in life that feel like there is no one there for them. They out here by themselves. And I always use my platform to show them both sides of this, good and bad. It's only but so much a brain seated in the ghetto can tolerate, the feeling of losing before it tells itself to win. No matter the cost, no matter the gender, and that's either the sale of dope, scam, blah, blah. I don't want to say that. Shout out to my country. It's the American way. But I wanted to emphasize this because how often do you see a young Black male that's actually been injured that has bought into the concept of mental health therapy and is willing to publicly state it on Instagram and show his session on Instagram Live? I think that is a testament to the incredible work that our staff has been doing and having culturally competent psychotherapists that can work with these young men to address their trauma. So one of the things I would also add is I just recently published an article called Staying Out the Way, and it's on the perceptions of using Uber Health to get our patient population to and from our psychosocial services. This is Uber Health, which I don't know if many of you know that there's an Uber Health division where Uber Health actually can schedule your patients to arrive at their appointments on time, which takes their responsibilities out of the community-based organization or health organization's hands. So our young men described in that article through our interviews and focus groups why they felt that Uber Health was so important with connecting them to the program. This article was written on ways that the emergency departments and hospitals can document police-involved shootings, because what we know is that only 3 to 4% of law enforcement agencies actually report fatal and non-fatal shootings, and we don't have no idea right now how many people are non-fatally shot by the police every year. And so this is an article that I published which looks at that issue. These are some of the ways that you can code for a person that medical staff can code to document when someone has been injured by the police, which we should be using as an alternative approach to documenting police-involved shootings, which the healthcare system can do. And then I would like to say that the Department of Health and I had written the letter of support for the DC Department of Health, and you guys, the DC Department of Health was recently awarded the FASTER grant, which will document in real time firearm injuries across all the trauma units in DC. And so I was fortunate to be asked to write the letter of support, and DC was one of 7 cities to get that grant. At Maryland, I'm the executive director of the Travail Transformative Research and Applied Violence Intervention Lab, and we conduct studies that are used to inform the implementation and development of innovative violence intervention programs. And I also would like to say the way that I ultimately created the CAPVIT program was I conducted research using Prince George's Hospital Trauma Center as my lab. And then that 2-year study with young men who were injured actually led to the development and implementation of the program. And so my work is translational, and I believe we should use research on gun violence that translates into innovative interventions, but also evaluation to know what works and what doesn't. And so the lack of research funding for gun violence researchers as myself, again, has left a huge void in what we know about what works and what doesn't. I will show this clip because it's pretty short.
Art Killerman did research decades ago, and the research looked at this idea of, does keeping a gun in your home make you safer? And he found that people with a gun in the home were more likely to die of a gun injury than to be saved by one. And after that, Congress put a restriction on the CDC called the Dickey Amendment that said that the CDC couldn't pay for gun research that promoted advocacy of gun control. Now, I've been looking for years on how much it costs our nation every year for people that have been shot that are getting long-term care services because of spinal cord injuries or traumatic brain injuries. So people that are in wheelchairs or chronically on a ventilator because they've been shot and are living in, essentially a nursing home the rest of their life. I can't find that data.
That was Kyle Fisher, who is a colleague of mine and also one of the co-founders of the program at the hospital. And that just, I think that articulates and captures why gun violence research is so important. And so I would like to acknowledge a colleague of mine is a colleague of yours, Kenny McDuffie, who I think is creating some really innovative steps towards addressing gun violence in the district. And in terms of the lack of gun violence research funding, I know that he had proposed that the district be the first city in the country to create a gun violence research center, which I just think is an incredibly awesome idea. And I would suggest as one of the recommendations, if DC, as the nation's capital, would like to take the lead as a pioneer in this field, I think that we should be ahead of the federal government in understanding why gun violence is happening in the District of Columbia and how DC could be very pioneering and path-breaking in creating a center for gun violence research. So the last thing as I get to a close, the programs definitely need to have reliable funding. And I discussed in the beginning of this how California has seen huge reductions in gun violence because they've been willing to include it as part of their state budget through CalVIP, which is their violence intervention program for the state. But unfortunately in Maryland, I am a member of the Maryland Violence Intervention Prevention Program Fund, and we were supported early in 2018 through that fund for there was a $3 million fund which supported 10 programs across the state. Mine was one of them. And in 2020, Governor Hogan decided to veto that bill at a time when gun violence is spiking across the state of Maryland. This is the young man, Marjay Powers, and this is myself and Che Bullock at his graduation from Ballou High School. And as you can see, he's holding his diploma. He was also involved in our program. But one of the things that I would like to say in terms of why funding is so important and needed is that during the time that we were providing services for Marjay, when the program started, the program of funding started being effective, Che ultimately left the program, and Edward McCurdy, our psychotherapist, who you saw was working with Christopher Edge, also left the program. And that left a void for a number of our young men to provide support services to advance young men such as Marjay Powers here. And he was also in a program in DC called Run Hope Work, where he had received his credentialing in carpentry. But unfortunately, because we didn't have the funding to keep up with young men like Marjay, this ultimately happened. So on November 12, 2019, Marjay Powers, or at least on November 11th, Marjay Powers was killed in Southeast DC. And so he was one of the 166 young men that was killed in DC, and I sit on the DC Violence Fatality Review Board. And so I would like to just sum up to say that I dedicate this project and all our research to him. And I was asked as well, could I comment on girls who have been victims of homicide or victims of violent injury? What we're seeing in Baltimore right now is and I'll just stop right here. What we're seeing in Baltimore now are young women who are coming into our trauma unit for violent injury. And what's unfortunate about that is we have 25 young women who have been shot within the past 3 months that are all associated or affiliated with young men who are in the street. So unlike years before where we would find young women that are coming into the trauma center for interpersonal violence or DV, Now we're finding far more young women coming into the trauma center who have actually been the victims of gun violence, either fatally or non-fatally. So I'm willing to take any questions that you may have about my presentation and the ways that I could make suggestions or recommendations in terms of what gun violence strategies or reduction strategies should be effective in the district. Thank you.
Go ahead, Samantha.
I was actually gonna ask Sultan how he wanted to do it because I saw he unmuted first. Oh, we can't hear you, so I'm guessing you're saying go for it.
There you go. Sorry, I'm on my phone. I have my phone muted too. So yes, I was saying I was just going to thank Dr. Richardson and then say go for it. Go for it.
Awesome. Thank you, Dr. Richardson. I actually have a lot of questions. That was an amazing presentation and definitely appreciate it. Most of them are geared towards recommendations. One would be, one of the things we've been grappling with is this concept of violence interrupters that we have here in DC that seems to be effective, and certainly in my opinion, much more effective than police officers are. But there also seems to be like a need to expand that work or build on top of that work. And so the graphs that you showed, or the maps that you showed, I think you called them maps of shot spots, or where the gun shootings were happening.
Correct.
Do we, if you know, do we currently place violence interruption teams in those specific areas? And could that be an effective way for us to identify like how many squads we should have and where they should be placed based off of those points in the map, if that makes sense?
Yeah, so there are teams of violence interrupters that overlap those spaces where you see a high concentration of gunshots. But what I would emphasize is that while you may have a violence interrupter team that's in one neighborhood and they've been able to decrease violence significantly, you could have a neighborhood on adjacent sides that are seeing spikes in violence. And the problem is that do you continue to fund programs where you're placing violence interruption teams in every single neighborhood, or do you actually allow the violence interruption teams to be more mobile, right? So in times where you're unable to completely fund violence interruption teams to be in every neighborhood that has a high rate of gun violence, which I think is pretty much impossible unless you just have a load of money, how can you maximize the effectiveness of these programs by allowing them to be at least more mobile and moving around the wards in that have high rates of gun violence? And that seems to be, that's a problem with the model, right? I don't think that's necessarily an issue which I don't know whether this committee can address or not, but one of the things that scholars who do work in evaluation of these programs have found is that one of the hindrances is that they're not really mobile. So they can't move around in ways that they should.
Can you talk a bit more about that mobile piece? I'm sorry, I just wanted to hear more about like what that would look like for you. And also curious, working from like a abundant worldview of not thinking it's impossible, although I hear you, to have like violence interrupter squads in all of those areas. Like, is there value added outside of the restriction of money to try to do both?
And Samantha,
There
can
is.
I'm sorry, can my question is also about that. Do you mind if I just follow up to put a finer point on it? Because, so my question about the violence interruptions being more mobile. I'm the most familiar with the OAG's model of violence interruption, the Cure Violence program, because it's where I work. And my understanding of the way that program works is the folks really get to know the people in that neighborhood and the dynamics in that neighborhood. And that is how it is that they're able to interrupt violence. So I hear you saying that's a problem with the model, which I understand because a model like that couldn't be more mobile. So I can't understand how it could be. So I'm really interested in hearing more about like what the model does look like in order to be more mobile.
So for example, let's just say your beat is 10 blocks and you establish that 10 blocks as your beat. You've been able to reduce gun violence within those 10 blocks, but you have an adjacent community where there's no violence interruption team. right? So it's an either or. So either you have enough funding where you're able to place another violence interruption team in that 10 blocks. It has an absence of that team, or you rely on the credibility, the street credibility of that team that's been able to reduce gun violence in that 10 block radius to shift over to respond to gun violence and flares of gun violence that's happening in the adjacent community. And we see it all the time in terms of violence interruption. You could have a beat that's 6 blocks, and 6 blocks over, there's a war happening, right? But because the city, the model is not responsive to emerging gun violence, that community absolutely gets nothing. So unless you come back again to the city council to re-up for more money to add more people to that, to reduce violence in that neighborhood, it's almost impossible. So that neighborhood gets left out. And so if the model is able to be at least more mobile to address gun violence as it flares up in the surrounding communities, it's possible that it could be more effective.
Can I just ask, I want to make sure I understand. So, but there's 2 ways you could do that. One would be to have a model that's more mobile. One is just to have more cure violence programs covering more of the city.
That's true.
Yeah, okay.
I think my response is based on the way that the city budgets look right now. Right. So there's one response to the way that the city budgets are right now. And there's another if the city is willing to make the investment to have cure violence models across neighborhoods throughout the city that are experiencing high rates of gun violence.
Thank you.
Sir, do you think, Doctor, there is a substantial need for substantial police presence in places like wards 7 and 8 at the present time?
No. I still believe that these models are effective, and I think that the presence of the police, while the police may have great intentions, I don't think that the community level of trust in the police is there. And the non-law enforcement approaches to violence have proven to work, but we just have not invested in them in the same ways that we've invested in the police.
Would you eliminate the police altogether in those?
No, I would not.
But
and I don't think it's an either or proposition that we have to choose one or the other, but I do think that police need to be better trained. And I do think that there need to be more investment in community-based violence intervention approaches. So I think that, you cannot eliminate one without the other, but I also believe that there should be alternatives to calling the police when you have a mental health crisis. And so, for example, I'm a resident of Philadelphia. Recently, a month ago, Walter Wallace was killed by the Philadelphia police. They had responded to the incident of Walter Wallace's home the 3rd time when he was shot. That was the 3rd time that day that they had responded to a mental health crisis there. Do I think that the police should respond to mental health crises? No, I do not.
But how does the policeman know at the front end when they get that call from a citizen who is at risk? How do you know if it's a police issue, if it's a mental health issue, if it's a violence interrupter issue?
Because that should be determined on the front end when someone is making a call to 911. So let's use Walter Wallace, for example. His parents have called 911 well over 15 times to respond to his mental health crisis. And so I think when a parent or someone in the community is experiencing a mental health crisis, there should be an alternative number that person could call. Or the mental health crisis therapist should arrive there before the therapist, or in conjunction with the police, or in conjunction with the police. I mean, there are multiple ways that this model can be played out. I think some cities are starting that, like Philadelphia now has behavioral therapists that are actually go out and respond to those calls. And the District of Columbia has the opportunity to adopt that model as well.
Dr. Corey, just a sec, Ron, I just wanted, because I think Corey was trying to get a question in, so I want to.
I was listening. I love the presentation. I do. But on a preventive measure, I want to know, like, how can we work around a preventive way that even when you do a violence interruption, or when you do squash a beef, or you kind of, you put these things in place that can be effective in that community, what's the preventive way that we can go about assisting that individual or that community or that person, right, to stop engaging into criminal activity? Because I live in my neighborhood. I've been there, wow, long time, on both sides, right? On that side and on this side, right? And what I do know is if they don't eat, they gonna hunt, right? That's a term we use in the community. If they don't eat, they gonna hunt. So how do you stop people from hunting?
Give them a job.
You have to address the reasons why they're not eating.
That's right.
Right? With all those forms of structural violence, which I tried to illuminate in the beginning. And in terms of, let's just say the Pathways program, there's no reason why we don't expand those kinds of programs in the communities. The problem with the Pathways program, and as great as it is, it only can accommodate a certain number of people. I cannot tell you the number of young men that I've had come into our program that I would want to refer to the Pathways program, but all the spots were taken.
Right. So and that's where I'm getting at, because a lot of times we look at how much money we can keep putting in violence interruption, but we don't put it in prevention. So now, like, it has to be some type of money allocated to expand another one's office, or, you know what I'm saying, or other programs that will be able to assist these people that are really willing to come out of that environment because they're really tired of it, right?
Right.
But they don't have anything to do, right, when you do pull them out of that environment. So I think another one of the most critical issues that I have is that, yeah, violence interruption work. I've seen it work. I've been there. I've been in the midst of things that can work. But how can we keep the preventive measures, or how can we prevent these people from going back to this regular lifestyle that they're so familiar with when they don't have the opportunity that you're talking about?
But you have to, and I agree with your points 150%. And one of the things that I would say in terms of my research is that conducting the interviews and focus groups and observations, I listen to what my guys want. And once I understand what they want, then I provide the resources to get them there. The problem is that we impose what we think should happen. That's not good research.
Right.
And that's the problem with the lack of research that's happening on gun violence right now, is that we're not taking or empowering the individuals that we work with to determine what they want to see as a positive outcome and how they want to get there. So when a young guy tells me, well, you know what, Doc, I would prefer to come to the school to receive these services, then some way I have to make that happen, right?
Right.
So ultimately, what I'm doing had to work because only one person came back. Right.
So,
what I'm just saying is, in our sense of paternalism, we assume that we know what's best for our population.
That's right.
And I thank you for saying that, Doc. I'm gonna say this and I'm gonna close on my side.
Sure.
So the other piece that I have that I look at a lot is that, okay, us, this panel, this commission, everything, right, that's going on. We are always trying to, figure out ways and means to assist the individuals, young, juveniles, whatever you want to call them, right?
Right.
But the other issue I have is that they're never at the table, right, to express, right, their issues. So if they're not at the table, they're on the menu.
That's my point.
You get what I'm saying? So now I'm going back to us really having, not only us having a conversation, but also bringing in these people that are affected, right, by the issues that they're really wanting to change. And so if you, again, the answer is in the problem, right? And so most of the time, if we talk to the individuals that's in the problem, we'll get the answer, because
we'll get the solution.
They know what they want.
Exactly.
So a lot of times we're trying to gauge in how they need to work or how they need to live or whatever the case may be. and it's not effective to them because they're not transparent, or they're not listening to, like, you always, like, everybody's always trying to tell me what to do, right?
Exactly.
Instead of you listen to me.
Exactly.
I'm sorry. I just had to.
No, and I would say, Corey, I would say to dovetail on that point, Corey, I would say, as a scientist, there's a methodology called patient-centered outcomes research, which basically means that I work with patients and empower patients in the decision-making and what they want to see as an outcome. And once I understand that, what they want as an outcome, then it's my job to provide the resources to achieve that.
Definitely.
Right?
Definitely.
So, for example, Uber Health, our guys were saying they didn't want to take public transportation. They felt safer on and riding in Uber. Well, let's do that, right? They said that they want to get the services at school, because let me tell you, when we were providing the services at the hospital, two things that they told me in the focus group. One, bringing them back to the hospital was a re-traumatizing experience because they had just been there 2 weeks ago, almost lost their lives there. Two, it was a safety issue because our catchment area is 20019, 20032. So if you have a beef with someone who was just shot there and they have their crew up at the hospital and you're coming to get services, the likelihood of you running into that person that you have a beef with is really high. Yep. So what does that mean? I need to change where the services are happening, right? That came from them, not me.
Yeah.
Those were things that they articulated, which I had not thought about.
Right.
Right. So if you left it to Dr. Joseph Richardson, I would say, well, why don't you want to have the services at Prince George's Hospital? Right. Yeah. But they articulated, well, these are the reasons why, and I won't engage in the services unless you're able to change that. But again, how often do we have the people that are most affected, empowering them with a seat at the table?
Right.
And that's what we really need to focus on in our approach.
Definitely. Thank you.
Thank you.
Ron, I think you.
Yeah, I would, Blaine, thank you. I wanted to add a couple of things. In the dispatch community, there's something called managing calls for service. And those departments that have and utilize managing calls for service simply mean that the dispatchers have been trained to get to the issue of what it is that they want the police for, or if it's non-emergency. And that's how those communities, other than Washington, D.C., have been doing and developing responses to calls for service for individuals, for example, for that are experiencing mental health episodes and those kind of things. And that can be done here. I have a short clip, and someone has sent it to me right after I had viewed the clip of the guy in Philadelphia that was shot and killed by the police, and the clip is of police officers in the UK, in London, where a man was wielding a machete, and it was 2 or 3 police officers was on the scene first. They simply called for resources, and the resources was those body shields that the police in America use for demonstrations, where they had about 20 people who had the shields, pinned the man in, took the machete from him, put handcuffs on him, and took him to the hospital because he needed to go to the hospital. And it's not just simply, that wasn't just simply because the police in London and the UK don't use guns. That was simply because they used their head and they were interested in saving life rather than taking someone's life. That could be used, that strategy could be used here in America. All we had to do is think about it and do it.
Right.
As well as utilize managing calls for service and alternative measures to respond for calls for service when we have it, and utilizing dispatchers to the extent that they can to find out exactly what it is that people want, because they have time to do that. Every call isn't an emergency call, and especially when the research showed that when these kind of calls or situations go down, the people have called the police a number of times. All we just need to do is pay attention to it and then be able to do it. But we certainly don't need more police.
I agree, Ronald. And what the other thing that I would also mention in terms of just innovation, I think that, yes, there are a lot of great programs out there and they're evidence-based, but I also think there's room for innovation in supporting other programs and models that we have yet to be tested. I'll give you an example. So when I started the program, we were using a CBT model called MTREM, Men's Trauma Recovery Empowerment Model. Some people that work in criminal justice know that model very well. It hasn't been tested with violently injured population, but with criminal justice and substance abusing populations. And so you have to ask yourself, like, how does a model get to be evidence-based, right? Ultimately, it has to be tested and maybe an RCT. But there are also innovative models that my psychotherapist had that he developed. But because we were so married to the evidence-based model, his culturally competent and tailored model for our population, I didn't use. I regret that, right? Because there could have been that the same way that other models get to be evidence-based or evidence-informed, we have to be able to take the intellectual risk to use models that may not have been used before to get to the place where they're evidence-based, right? And that takes risk for us to use with the populations that we work with, because the people who are doing the work on the ground clearly understand, and I would say this for clinicians, that there are a lot of gaps in the ways that these models are used with certain populations. So I think that we also have the opportunity to be much more innovative with just moving outside of, cure violence and safe streets, and looking into other models that may just be more tailored for the District of Columbia, that aren't necessarily tailored for that may be tailored for Los Angeles or Chicago, but they may not fit the narrative for DC. But ultimately, again, I emphasize how much research is going into understanding what works and what doesn't. Unfortunately, tonight I couldn't provide you with any data on an eval impact, because right now I don't have that data.
Dr. Richardson, if
Yes.
I could ask a little bit more, we've been talking about funding a lot,
Sure.
and the defunding of some programs, not having enough funding, whether we're talking about prevention or intervention. And I also heard you say both, you don't believe we need a substantial police presence, but also curious about, and also that we don't need to eliminate police presence, but wondering if there's a balance. And you don't know this about me, everyone else does. So I've been organizing and advocating around defunding MPD and redirecting those funds towards community-based intervention and preventative programs. And so curious, in the world where if we believe our communities are over-policed, to reduce that police presence, like what would be, is there a way to do both, to like what would it look like to divest from police in those communities and invest in these other programs that we know to be more effective and in some ways more cost efficient? And so curious if you've given any thought to that and what that will look like for you.
So I think that the best way to probably achieve it is to slowly scale down while you're scaling up, right? And to determine whether, as you're gradually scaling down and scaling up, whether there are any changes in the impact and violence in that community, and whether the reductions are happening. I don't think that the sudden just defunding the police and eliminating the police altogether is necessarily going to be the answer. And I don't think scaling up all the way is going to be the answer either, because we've seen, I've seen that in Baltimore with their Safe Streets program, where they scaled up immediately, but then they've had all kinds of issues in terms of scaling up really quickly over like 1 year. Trust me, because I'm dealing with it right now as I work with them. They scaled up 6 sites quickly, and they're now in a point where they're questioning whether they had the actual resources and technical support to do it so quickly, right? So I don't think that there's like a one size fits all approach to it, or one should be eliminated for the other. I do believe that there needs to be a gradual scaling down of the police in those communities and a gradual scaling up of the violence intervention programs.
Thank you. I'm just going to push just to see, as we're creating recommendations, do you have any thoughts on what that gradual, if it's like a percentage or like a number of police officers per like violence interrupters?
That I don't, but I would say I would defer that question to my colleague Rashawn Ray or Philip Goff, who actually do the work on policing that are far more experts in that area than I am. But I don't know what the percentage would be, but I think that we've talked about scaling up and scaling back, and I don't think they've arrived at a percentage either, but I think that is the best way to approach this issue.
Thank you.
Dr. Richardson, I have it.
Dr.
Thank you
Richardson.
so much. This is incredibly helpful. I have some more questions around thinking about the models of violence interruption. As this commission, I think, will make recommendations around what violence interruption efforts should look like in DC. I'd love to learn more about. I think what I'm hearing you say is that one of the most important parts, and when you're talking about the mobility of the teams, is credible messengers.
Right.
I wonder also, I got this sense from your presentation that the hospital-based violence interruption program that you were running has been extraordinarily effective, perhaps more effective than other similar programs. I wonder if you could speak to what it was that in your program that you felt like was different that made it more effective.
The first thing I would say is I conducted the research before I decided to develop it. So I understood the landscape of the players who were involved, whether it's the medical staff, young men who were injured. I understood what their lives looked like post-discharge and prior to being injured. So with the understanding of the context of violence in DC through their eyes and understanding what the context of providing medical services within that specific hospital looked like, it made it easier for me to develop a program. Now, now you have other programs which the research is not really done up front. They want to start a program, they'll take the model, they'll implement it, and that's that. And then they'll deal with whatever issues arise. That's not my approach. So I think that doing the research up front in the development of the program helped inform it. And then also what differentiates my background from probably other directors is that I'm trained as a researcher. So the entire time I was running the program, I was conducting research to inform whether it was working. It was always in a process evaluation mode. So I didn't wait 5 years out to do an evaluation to determine whether it worked. I was always evaluating whether it worked, right? And that is probably the Achilles heel for many programs, is that they're just not conducting continuous research as the program is evolving.
This is Bob, man.
Sure.
How you doing, Dr. Richardson? Thank you very much for your presentation tonight. It was very, from my standpoint, it was a very powerful presentation. I remember in one city that I managed years ago that had significant violence and homicides. The community awarded its highest award, gave its highest community award to the trauma centers at the hospitals. Mm-hmm. Because were it not for the trauma centers, the community would have experienced minimal homicides than actually occurred. Unfortunately, today's studies and the work that you're doing is a lot more advanced than what we experienced in those days, because it appears as if the work continues to take to look at and those individuals who survived gun violence and the impact that those individuals have, not only on their own personal lives, but in communities where they're residing, and the type of services that are required to be continued either through the public health services or through other social service agencies. And then my final piece is, I was really struck by the comment that Corey made with respect to, hearing from some of the young individuals within the community who have been, victims of violence, and hearing their issues as part of the work of this commission. But I also think it would be instructive to hear from community residents in some of those areas where your research so graphically pointed out the amount of violence. So we get a sense from those residents in those communities with respect to, whether or not less police, more police, no police should be considered. And then my final question is, the legislation that Councilmember McDuffie is proposing, has that legislation made its way to the city council, Blaine, with respect to the gun violence research?
It was introduced, but I don't believe it's had a hearing or any sort of process beyond that. So I'd have to double check, but if I remember correctly, it was only introduced and hasn't moved beyond that.
I would hope that as we continue, personally, I would like to continue a discussion with Dr. Richardson, because the other thing that he said that resonated with me is that while we have a number of programs in municipalities across the country that, we can learn from those, but we also have to focus on what is DC centric, as it were. And then the final piece of that is we can't just have programs that are aspirational, that someone just, we put a program in, but those programs have not properly been funded so that they have some type of, given a chance to work. And hopefully any funding for these types of programs would not come as a result of some grant, that at the end of the day, that grant goes away, then the program disappears. So anything that comes forward, it seems to me, would have to be embedded as part of the overall financing of the district strategies to reduce violence in the city, and not rely on a community grant that at the end of the day, may only be available for a year, even 2 years. Exactly. But the issues continue, and it doesn't give us enough time for these programs to mature,
right,
as it were. So.
No, I agree with, there were all great points that you made, particularly in terms of DC centric and understanding what's happening in DC. And I would just like to say for the record, so this year was the first year that the federal government funded gun violence research to the tune of $25 million. But I want to put that in scale for you. The cost of gun violence across this country is $229 billion. There was $25 million, 12.5 went to the CDC, 12.5 went to the NIH, and I applied for the CDC grant, got scored, didn't get it. But there are gun violence researchers out there who may have gotten it, and I applaud them, but $25 million is not a lot to spread around for people who are committed to this work. It's just not gonna, I could not sustain my career, honestly, on the ways that gun violence research has been supported, and actually discourages gun violence researchers from going into the field because there's just not enough funding for it. And so I would implore a lot of, and I see somebody said in DC police just got 50 million, right? So I would just implore this committee to support gun violence research in the district and be pioneering and bold enough to take that step that other cities aren't doing. I think California has been on the cutting edge of just doing a lot of really progressive things, which is why the rates of gun violence have fallen significantly. The other thing I would say and just emphasize, which I can't emphasize enough, is the mental health component. I just think that there's an opportunity for us to do all kinds of innovative things in the communities in terms of mental health. right? Whether it's teaching community residents emergency mental health first aid, right? So we don't necessarily, so the communities within the communities, we could be providing that treatment until we get somebody to professional help. That should be happening in the district. When a youth offender gets caught with a gun, right? What I'm seeing now is that yes, we're moving towards de-incarceration and placing people on community supervision. But ultimately, when someone's caught with a gun, they should be diverted to wraparound services. Placing someone on probation on probation is just not enough. And it's proving to be the case, because what we're seeing again and again with people, young people who ends up on the homicide list, as my young mentee Marjay Powers, yes, he could get caught with a gun, be placed on probation, but if he's not connected to any services through the courts, and there should be a special court that addresses these issues where someone comes for a gun charge and they're diverted to wraparound services. They're diverted to a hospital violence intervention program. They're diverted to pathways. Why is that not happening? Why are we just comfortable with not incarcerating someone who gets caught with a gun and just placing them on probation? It's just not, it just doesn't go far enough. Because ultimately, if that person was caught with a gun, trust me, in DC, where people feel like they have to protect themselves defensively, not that they're using a gun because they intentionally want to injure someone, because many are often scared, right? Which is why they're carrying a gun. So these are things that we just really need to be much more cognizant of. And I know that there were going to be trauma centers that were placed in communities with high rates of gun violence. I don't know what happened to that in terms of the funding for it. I thought that there were supposed to be 3 centers, and now I'm hearing that there's going to be 1. But the mental health component is critical, getting people that are affected a seat at the table. As was mentioned, in terms of the citizens, the adults who live in those communities, and the people. And I just think that we often make decisions without really getting input from the people who are most affected. And ultimately, we should have truth and reconciliation commissions within these cities. And I agree with Councilman McDuffie's point in terms of, this is another discussion, but I think it's very tangential in what I presented in terms of the racial wealth gap. There should be no way in the world that the racial wealth gap is 81 times greater in the nation's capital. That's ridiculous. And that's what we haven't talked about. There's a wealth component which has to be addressed. It cannot remain the elephant in the room, the 500-pound gorilla in the room that we just choose to sweep under the rug. So it's a hard conversation. It's an uncomfortable one, but it's a conversation that must be discussed, because that you can't educate yourself out of that. And I know that the work of Sandy Darity, who's at Duke, is a labor economist who's done this work, has proven that there's no way to educate yourself out of that kind of wealth gap.
Well, communities will not progress unless they're prepared to engage in those very difficult conversations and come out of those conversations with some strategies to move forward.
And that has, right, and I agree. And that has to be seen as a form of violence reduction, right? Not just, and that's why I presented on structural violence. Structural violence has to be included as a form of violence reduction, because I think that when we talk about interpersonal violence, we blame it on an individual, in which the individual should not be blamed, and not really placing the blame where it should be. The blame should be placed on the structure that created the conditions that were violent for someone to engage in violence. People aren't inherently violent. They live in violent conditions.
If I can ask, and I'm mindful of the time, so if you can't answer this, I would love to just put it out there for the record for us to have a further conversation about it. I mostly appreciate you rooting this whole conversation in structural violence and state sanctioned violence. And one of the specific ways, in addition to the economic piece and the wealth, you name the trauma centers or lack of trauma centers in Ward 7 and Ward 8. And just
Right.
want to get clarity. I know a lot of people, and appreciate all the organizers who have been working around the hospitals in Ward 7 and Ward 8 and the closing of United Medical Center. I was under the impression that the trauma center that was going to build was a level 3 trauma center, not a level 1. Would love to get clarity on that. And if it is indeed a level 3, if you can explain like what is the difference? Because I was hearing you emphasize level 1 and the
So
necessity.
my understanding was it was level 1, but I could be wrong. And the difference between and to place a level 3, I don't think would leave it as a trauma desert. So level 1 and level 2, the difference is primarily is a level 1 trauma center is typically is associated with a Research 1 university, but is also fully staffed. So they have a neurosurgeon, cardiovascular surgeon. Those surgeons aren't on call, right? So if someone gets, let's say, for example, shot in the head, they may be, because Prince George's may be the closest hospital to where they need to be brought to, they may be brought there and there may be a neurosurgeon on call who can address it. But typically that person will ultimately get medevac to shock trauma in Baltimore, right? And so there's the difference between just the level of staffing that occurs in level 1 and level 2 trauma centers. There's a difference in that. So, and then there's a lot of issues around cost as well. But I think someone posted it. Did you just post that?
Yeah, it's the most recent article I could find. I know the fight was happening in the spring or in May, but we'd love to follow up on like what that is, because I do believe, as you continue to emphasize, that this commission should include recommendations to address various forms of structural violence. And
then the last thing I would say in terms of policing, and I think, Christy, you may have mentioned it, I saw briefly your chat. One of the things I did not show, which was, and I could share with you in the PowerPoint, is the abuses by the jump out squads, and particularly the gun recovery unit, right? And so I have one young man that was in my study who was actually shot by the jump out team, who jumped out. They didn't identify themselves, no badges, no clothing that indicated they were the police. And because he's carrying a gun and his friends are carrying a gun and they're defensively carrying guns, they fired at them. Police shot back, hit him 5 times. He had to wear a colostomy bag ended up going to jail, spent 3 years with a colostomy bag on, gets back out. Now he has a felony. As I want to show you the cycle of violence and impact of a felony conviction. Within 10 months, he shot again 10 times. Comes into our hospital violence intervention program, approaches him, a violence intervention specialist, gets him into the program. He starts going to therapy. And in a conversation, the violence intervention specialist asked him about his colostomy bag. The young man tells him he's been wearing it now for, I believe, like 4 or 5 years. Immediately sets up an exam with our trauma surgeon, who finds that he should have had the colostomy bag taken off 5 years ago, right? Gets an emergency surgery set up and the bag is removed. But can you imagine all the psychological damage that person had to experience by wearing a bag for that period of time? That's a form of structural violence, right? The correctional healthcare system and the healthcare system failed to that young person. So again, I know there's a multitude of issues that I could talk about forever, but I hope that this conversation has been, at the very least, enlightening on these issues.
I just, at the risk of stating the obvious, thank you so much, first of all, for this really, really helpful presentation. I think, again, at the risk of stating the obvious, what you made so clear, at least for me, is that if we really want to reduce gun violence in order to save lives and prevent injuries and improve quality of life, if that's our end goal, if putting people in jail is not our end goal, then we have to look far beyond policing to figure out the solutions. We have to, I mean, you're talking about hospitals, you're talking about gun violence, about research, you're talking about all sorts of things. And I think that's what this commission should do, that we have to recognize that we're called the Police Reform Commission, but that's because we've allowed police to occupy the entire field for reducing gun violence. And that's just wrong. It's not morally or ethically wrong, it's just factually wrong.
Right.
And so to fix that, we have to look way beyond that in our recommendations and in how we explore this.
That's right.
Hi, everyone. Just one more thing. Thank you so much, Dr. Richardson, for your presentation. I think one of the other things that really struck me is that we have an opportunity to, obviously learn from the national models, but to also design and recommend, put together a set of recommendations that can be tailored to DC and to the DC context in a way that's really responsive to all of the rich data and information that you've shared with us today. And that we don't have to be, confined to the solutions that have traditionally been put in place or currently are in place, but we can think creatively, using a lot of the data and research that we already have at our fingertips. We already have this information. And so I know that, at least for me, after your presentation, I have so many other questions and follow-up that I would want to discuss with you. And I think that, if you are open and willing to have this be the beginning of a conversation with this committee as we're developing recommendations, to be able to come back and ask some of the follow-up questions that I think some of the commissioners still have, but we may not have enough time to delve into today.
Definitely, I would love to. And I would also say, just as, and I don't know whether I have the authority to say it, but I'll beg for forgiveness. I'm also a member of the Fatality Review Committee. And so I think that the recommendations that are coming out of that committee in terms of what we're finding in our assessments of some of the reasons which led to young people becoming victims of homicide in the district could also be used, I think, with this committee, and you should be sharing information with that committee as well. So, I'm excited to have the opportunity to work with this committee and look forward to future conversations. Okay.
Thank you.
Thank you so much.
All right.
Thanks a lot for joining us, Dr. Richardson.
Thank you. And let me know, Blaine, if I can share the PowerPoint that actually has the clips in them so you can see them as well.
Yeah, please do. And I'll circulate it to the committee and the full commission too.
Thank you for having me. Have a good night.
You too. Thank you.
Thank you. You too.
Thank you.
And for the commission, it looks like there were, excuse me, 2 other agenda items. If we have the time to briefly run through them, the second one was a report on the Impact Justice memo that was circulated. For the Impact Justice team, do you want to talk through that memo?
Honestly, I really think that that Dr. Richardson's presentation covered a lot of what we were trying to establish in that memo, that there's a good base of evidence for the strategies that the district and other cities are using in terms of community-based violence prevention. And he actually offered a lot more nearby evidence than is in our memo, which is more national in scope. So I don't think we actually really need to take time to do that now.
Sounds good. All right, thank you. And then the only other item was a report on the meeting that happened earlier. Lashunda was going to do that, but it looked like she dropped off. Is there anything that the Impact Justice team wants to report out about that?
I don't know, Christy, do you want to say anything about the conversation with Eric that might be particularly useful in the context of this presentation, or we can just hold that for now?
I mean, all I would say is that the experience in New York with violence intervention has been similar to the experience in DC, which is that the combination of violence interrupters and providing services does seem to be reducing gun violence. And he had some ideas for how to make that more effective and how to expand that we can go into later.
Sounds great. Well, I know we're over on it. That was the end of our agenda. So unless there's anything else from the commission, we'll do a adjournment here.
Yep.
Good.
Thanks a lot, everybody.
All right,
Thank you.
Have a good
everyone.
night.
Night.
Bye.
All right, good night, everybody.